Okay, so we now move on to think about negative symptoms of schizophrenia psychosis. And I think it's fair to say that negative symptoms are often viewed by family members as the most frustrating of the various symptoms of psychosis. So, in this session, we're going to think about negative symptoms and CBT informed caring techniques, which might help negative symptoms to gradually start to lift and enter a recovery trajectory. So, what are the negative symptoms that you might see in a loved one with this disorder? Well, the first one is that their emotions may seem very blunted. So your loved one might appear mask-like, and there isn't the kind of emotional resonance that you would normally have with someone you speak to. And it is this interplay of emotions and ideas which allows conversation to be maintained. So very often you have to check in with your loved one who is blunted and say, well, what exactly is it you're feeling just now as we talk about this? Are you feeling nervous or sad or a bit more angry? Because you won't be able to detect probably what that emotion is. Now, people who suffer this do say that the feelings are there, it's just that they can't express them. Now, the next one of the negative symptoms after lack of expression of emotion is a lack of content of thought and the lack of amount of thought. And this reflects in the fact that they've not got much conversation. They don't actually come up with very many different or new ideas. They have a narrow range of thought. So your ability to have a rich and varied conversation with a loved one with this symptom will be restricted. So the next thing that's switching off in negative symptoms is drive and motivation. So a loved one with these negative symptoms of loss of drive will just not seem to want to do anything very much. They might just sit in a chair, they might just stay at home and not show any great interest in meeting friends or going out to do any kind of activities. This leads into the next one. If you don't have that kind of motivation, sometimes self-care is also lost. So the understanding that teeth need to be brushed on a daily basis, you need to have a shower fairly regularly, you need to get clothes cleaned and from time to time replaced. This very often won't happen. So you'll have the same clothing getting worn for long periods. It'll start to become tatty and a bit smelly, and they don't seem to recognize that that's not very acceptable to other people. Sometimes clothes are worn in a strange way that really looks quite inappropriate. So self-care's getting switched off. And the last one is anhedonia, and this means the ability to feel pleasure. So in a negative syndrome state, it may appear that life is very flat and there's not much that is actually being enjoyed. Now, people that have this symptom and talk about it say, yes, they do feel flat, but they can experience pleasure in certain situations. So thinking about what's happening in the brain in people with negative symptoms, there are a number of different components to this. Now, the first thing is that this crucial chemical of dopamine seems to be reduced in activity in the prefrontal and frontal brain areas. Now, this needs to be compared to the fact that there seems to be a bit too much dopamine activity in the limbic and temporal areas. And of course, it's that excess dopamine which is partly involved in maintaining voices and delusions. But the rundown of dopamine in the frontal areas seems to be involved in negative symptoms. Now, this rundown of dopamine means that we don't get normal rewards. The system is switched off. We don't get a normal feeling of pleasure. We don't get the normal feeling of achievement when we do something. And this is something that CBT can start to switch on again. Now, some people with negative symptoms do clearly seem to be doing something different. And that is that they're very stress sensitive and they're actually hiding away. So it's a relief from too much stimulation, which they might get in the outside world. So that's really about anxiety, stress, and hiding away from that. And if we work with the anxiety, people getting negative symptoms down that pathway can start to feel a bit stronger for facing the world again. Now, Dr. Beck and his team made the crucial breakthrough of showing that people with negative symptoms tend to have self-defeating beliefs and attitudes. So these are really thoughts about failure. They will say things to you, what's the point in getting up for the day? It's not going to work out well. Or why would I bother having a conversation? I know I'm going to sound weird or stupid. So it's all very defeatist. Nothing's worthwhile, nothing's going to work out. And of course, these very negative defeatist beliefs can be worked with. And that is something that CBT-informed caring can help with. Now, along with negative symptoms, when you get a lot of negative symptoms, you often have cognitive problems as well. Now, not everybody with schizophrenia psychosis gets cognitive problems, but some people do. And this is in the mix that needs to be considered. So if you have a loved one with problems in maintaining attention, problems with a short-term memory, and real difficulties in planning out what they're going to do, that is a separate issue, and that needs to be thought about in its own right. So can they be treated? Well, the short answer is yes, but it may take a bit of time. Now, negative symptoms that are secondary to other things are more easy to treat. So negative symptoms secondary to, for example, hallucinations or delusions, in that case, the hallucinations or the delusions are the main problem. And if we can get some progress with them, the negative symptoms will improve. Sometimes negative symptoms are worsened by the side effects of the medicines. And that is something that needs separate attention. And sometimes it's depression that's worsening these negative symptoms. So if you have any of these causes, they can be treated by doing something with the pharmacology, doing something with the medicines, using cognitive behavioral therapy, and using family therapy. So they are secondary negative symptoms, and it's quite important we work out for our loved one, do these seem to be primary or secondary? Now, primary negative symptoms are a bigger problem. And if you think about how your loved one's psychosis developed, the primary negative symptoms tend to come on first. So quite often you will find, say, a young person at school, they're starting to get very withdrawn, they're not interacting as well with others, their self-care deteriorates, maybe their concentration's not so good, their homework's not getting done. These are probably negative symptoms that are developing, and then they develop paranoia or hallucinations. So these primary negative symptoms are still treatable, but they're a more difficult proposition. Now, if you have the cognitive bit here, say for example, your brain just doesn't allow you to plan out how to dress in the morning, that is a real puzzle to you, then we could use techniques from cognitive adaptation training. And this is something that Don Veligan down in San Antonio has published widely on. And this includes having signs and prompts to remind the person, for example, what order their clothes would go on in, or any other sequenced behavior, how you would approach it. And as they practice in that way, they start to plan a bit better. Cognitive remediation are a series of exercises to attempt to improve attention, planning, and memory. So that is something which can be useful alongside CBT-informed caring. Now, for real severe negative symptoms, you really want to have cognitive behavioral therapy. And it's Dr. Beck's team that have described this most fully. And that is going to take time to work. So, what about family members in relation to negative symptoms? Well, they typically express more concern. I mentioned earlier frustration about the negative symptoms of their loved ones. They're certainly concerned about hallucinations and delusions as well, but negative symptoms are an ongoing worry. Sometimes the loved one thinks that they're viewed as being lazy or just difficult. So really important to get the communication right so that they're not perceiving it in that way, because that appears like a kind of confrontation that worsens the negative symptoms. I think it's fair to say that family members do struggle to know what to do or say for a loved one with negative symptoms. Now, this video is going to give you a strategy. So here's an example of the kind of family interaction. Adam is a young man with psychosis with negative symptoms. He stays in his room a lot and he spends a lot of his time sleeping. The parents mean the best for Adam, but they don't know what to do with him. And they start to think, oh, maybe he's just being lazy. Maybe he could just try a bit harder. And when they go in to see him to try and get him up and about, they might come over as being slightly critical, slightly nagging, and the perpetual attempts to encourage him are interpreted by Adam as criticism, as they just don't understand what I'm going through here. And hey, they're critical just now. Maybe they're not bothered about me at all. Maybe no one cares. And of course, you can see that that is a perpetuating cycle. And this is something that we often see happening, despite the fact that the family members wish the best and mean the best and are doing their best. That's how it can come across. Here's another situation. Again, we have Adam staying in his room, blunted, not saying much, poor self-care, not doing much. This is a different family, and the interpretation here is, oh, poor Adam's, this schizophrenia, whatever it is, has really changed him. He is so unwell. Let's let him stay in there and sleep it off. Let's not encourage him. we'll bring his food into him. We'll bring his a toothbrush in and his razor in the hope that he might use it. And we'll bring him his food in. So this family is taking a different tack and they're actually doing too much for him. We need to find a middle way because Adam interprets this as, oh, everyone has given up. I'm obviously ill for life and I'm in this bed for life. And here again, we have a self-perpetuating cycle. So either of these can be problematic. We need to find a middle way. Okay, what about secondary negative symptoms caused by voices or delusions? Well, we mentioned some techniques for voices, and I mean, really, you would probably want to get some advice from your mental health professional if there were command hallucinations there. So if your loved one is thinking, I'm hearing the voice of God and I'm being told that I cannot leave this room or something bad's going to happen. If that is the situation, clearly we would like to help this young man understand that this probably isn't the voice of God, that it might be a quite different cause. It might be a symptom of the illness, might be caused by lack of sleep or stress. And if that's the situation, maybe it's not quite so scary, and maybe you don't need to obey what that voice says. So sometimes negative symptoms are secondary to voices, and here we want to work with the voices and get them a bit less powerful and a bit less distressing. If delusions are at the heart of the problem, we discussed techniques for delusions, start to come up with some alternative ideas, having asked questions about it, maybe demonstrated that it's safe to go to the window and look outside, or to actually go to the backyard and see who's out there. Test it out. Examples of this might be, if I go out, I'll be abducted by aliens who I believe to be monitoring the area, or that poisonous gas that's being produced will kill me if I leave the house. So here they stay in because of a delusion. So the idea here is to work with techniques for the delusion. What if the medicine has caused side effects? So sometimes you get a payoff with medicine that they treat the voices and delusions, help them a bit, but the downside is that they might worsen some of these negative symptoms. So this is particularly the case if the medicines are sedative, if they actually cause a bit of blunting anyway, if they reduce your pleasure or your drive. Sometimes this happens if the dose has gone too high on the medicine, or if multiple different antipsychotics are added one on top of the other, and maybe they haven't been reviewed for a while and brought into the correct dose range. So obviously this is one for your psychiatrist to consider. You would never change this off your own bat, but the psychiatrist may well, on review, say it's possible that this medicine could be worsening the negative side effects. So I'll bring the dose down by a notch, or I will switch to a different type of antipsychotic which doesn't have that side effect. So that's really one, if you think that's going on, to discuss with your psychiatrist. What if it's depression that's in there? Now, we know there's a lot of depression and a lot of anxiety in psychosis. So sometimes if a person's blunted, you can't actually see that they're sad or anxious. So we could ask about these kind of biological symptoms? Have they lost their appetite? Is their mood always down at one particular time of the day? So, do you feel worse every morning or every evening? Is there a pattern to how you feel? Do you actually feel very negative and pessimistic a lot of the time? And are you still interested? Now, the HAD scale is a useful scale. It's just one page, it's tick box, it's easy to complete, and it will give you a score on depression and anxiety. So that will give you a feel for whether one of these could be at the heart of the negative symptoms. Now, the best rating scale for depression is the Calgary scale, but this has to be used by a mental health professional. So you could always ask if your social worker or mental health nurse could do this scale for you. If it seems to be showing that depression is a big bit of the cause, we could ask for an antidepressant medicine. Now, these are often underused in schizophrenia. So we could ask for a medicine for that. And that type of medicine could treat anxiety as well. Or we could ask if we could have our loved one referred for cognitive behavioral therapy for their depression. So what I'm trying to say here is we need to try and get an assessment of the pattern of these negative symptoms and where they might have come from. Now, this does seem like quite a complex matter, but you will have a feel for this for your loved one, and you can check it out with somebody else from NAMI. You can check it out with a professional linked to your case. But moving on from this point, it's a balancing act. And we're going to be balancing very gradual goal setting with compassion and low pressure. So what I was trying to show with this picture is that this is quite a tricky balancing act, and it is setting up that balancing act in a way that it continues day by day, which will give you a chance of your loved one gradually re-emerging into the world. So primary negative symptoms, Dr. Beck's research has showed you're looking at 18 months of this very gradual approach before you're going to see a quite significant result. And thinking about people that I've treated over the years, I think the negative symptoms, you're looking at that time frame. Positive symptoms, voices and delusions, I would normally hope for real benefit earlier than that. But the negative symptoms, it's a gradual day-to-day build-up. Now, sometimes if you make this change at home and you move into this balanced communication style and you start to work with these gradual goals in the low pressure environment, your loved one might be puzzled by it and he might do a bit less for a period of time before we start to see some progress. Now, it's important to recognize that that might happen and don't worry about it. It's a retreat away from a change in the milieu. And if we can just keep going with our approach, that should start to come good after a matter of weeks. So it should start to slowly pick up. We're going to start to try and do some behavioral activation. So we're going to be explaining that we're all doing something all of the time. The question is, are we feeling that we're succeeding? And are we feeling that there's any pleasure in it. So this is the main strategy to help negative symptoms, apart from the low pressure milieu. It's to start to get the brain working again, to make small successes and to be able to recognize small bits of pleasure and to gradually build it up. We mentioned cognitive remediation exercises, which is good for if your loved one has those cognitive problems, and cognitive adaptation. So it's maybe worthwhile having a read at one of Don Veligan's publications if your loved one has those types of problems. Now, Dr. Beck and his team described a very famous result. He took people into his study of recovery-focused CBT for negative symptoms if their negative symptoms were extremely severe. So you had to really be very disabled to get into Dr. Beck's study. And no matter how disabled the people were, working in the way they describe in their publication and the type of approach I'm trying to put across today, people gradually emerged out of their negative symptoms. Even loved ones with the most severe negative symptoms can make significant improvement, but you're looking at 18 months. We've got to set the sat nav for an 18-month journey. In getting there, old hobbies and interests are important because it's easier to activate things which they used to be interested in and used to enjoy. As a family member, you will know what those previous interests might have been. And in all recovery programs, we see that altruism is important. So the minute your loved one shows any sign of showing an interest in helping others, that should be strongly encouraged. That altruism is a sign we're going in the right direction. We're going to be activating success modes of believing and thinking. So we're going to try and catch those negative thoughts, and we're going to be using more positive ways of thinking. We're going to be saying, you're saying that there's no point in speaking because you sound weird. Let's make a little audio clip of you speaking. Play it back. Hey, how does that sound? You sound okay to me. So maybe I think my speech is weird, but actually sounds not too bad. They can practice with these more positive thoughts. And thoughts like, I have previously achieved quite a lot in my life. There's no reason why I can't start to achieve things again and start to enjoy life again. So we've got to remember some points here as we go through this trajectory over 18 months. They might have problems with attention, planning, and memory. So keep it simple and repeat the key points. If possible, write them down, or maybe stick them up on the fridge or up on the wall so that they remember the things they're trying to do. If they make those early shoots of success and progress, lots of positive feedback about it. Work with defeatist thoughts, such as there's no point. One step forward and 2 steps back, that's me. And I'm going to sound stupid. Now, these are all the kind of types of negative defeatist thoughts. So let's try and identify them. And if we hear them, we're going to start to use some more positive thinking and ask them to practice some more balanced positive thinking. Anxiety often holds things back. So after a prolonged period of being in a negative symptom cocoon, they're often anxious about doing stuff and a bit depressed. So let's try and see if anxiety or sadness are there. And if they are, let's try and use the techniques we've discussed to help with them. Remember, old hobbies and interests are a good starting point. And with very many negative symptom people I've worked with, that has been the important starting point. Whether it be bird watching or an interest in certain types of food or cooking, or any kind of interest or hobby, coin collecting, stamp collecting, an interest in animals, whatever it might be, let's go there early and try and cultivate that interest and those feelings of pleasure, and then try and build some small targets towards success. We're going to be going very slowly, and you almost can't go too slowly. So one of the kind of biggest mistakes is your loved one shows a bit of interest in their old sport of fishing, which they used to enjoy. And you say, right, let's get the rod out the attic. I'll get us organized and we'll go down to the lake and have an afternoon of fishing. No chance. The anxiety levels are up. It all sounds like too much. They don't have the drive. They're scared of the conversation. They can't do it. And they feel a bit worse because of that suggestion. How about we find a fishing program on the television and we'll watch it together for 10 minutes? Now, you've got a good chance of success with that. And you might gradually build on that. And a few months down the line, they might say, I would quite like to try. We'll just go for half an hour down to the lake and have a look at where we used to fish. So you're kind of building up stepwise. So the tasks that we do, we're trying to slowly re-establish a basic routine. We're going to break any task down into small, doable bits. So in the fishing example, we watch the program, then we might show a bit of interest in a magazine about fishing, and then we might say, I wonder if we could find that fishing rod. Have you any idea where it might be? So that's the next thing, is to find the fishing rod, bring it down the stairs and put it in the corner. Next thing, how far away is the nearest place we can fish? Let's find that out. So it's a very slow bit of progress to gradually going to see where the fishing happens. And the fishing itself might be 12 months down the line. But going with these chunks of activity, you gradually start to get lift off. But you've got to keep going at the same slow rate, because otherwise they'll get a retreat into the negative symptoms. We can say, if we're reading a fishing magazine, could you try and read it for 15 minutes, and then we'll have a cup of coffee and a bit of a chat about whatever you've read. So are they able to manage 15 minutes of reading the magazine? And are they able to manage that little bit of conversation? If they manage it, loads of positive feedback. Hey, you've done really well there. I didn't know you knew all that about fishing. That was an interesting article, wasn't it? I really liked your comments about it. So we're given all this positive feedback about achievement and the pleasure linked to that. We're going to play it one day at a time. We don't project into the future. So we're not going to be saying, maybe in 12 months' time, we'll be out on a fishing trip. That will cause a retreat. We just do each day's target on that day and give the appropriate feedback. it would be good to gradually get other people involved. And that needs to be at the time that is right for them. It might be a peer support worker if one is allocated to your loved one. Some places have befriending schemes where a befriender would just come in and sit and chat for a bit and maybe eventually start to go out to the cinema and things. But befriending schemes are thin on the ground. It's quite difficult to find them. Someday they might say, today I'm going to go down to the drop-in and go and see who's down there. I'll come back after 5 minutes, just see how it is. If they are indecisive and putting things off, we can help them just hit the small targets of the day. And this starts to switch on those brain systems which were switched off. Now, I think family members are in a great position to help, particularly with negative symptoms. So this is an example of the activity schedule. And of course, when you first show this to somebody with negative symptoms, they say, well, I don't do anything, so there'll be nothing on it. So you would say to them, well, let's start with this first box here. So we're on Monday today. Between 6 and 7 o'clock, what was happening? Well, I was asleep. Okay, was it a good sleep? Because you know how you can get sleeps that are refreshing and you feel good after them, and you can get lousy sleeps. So how did you get on with this? It was an okay sleep. Well, let's score it out of 10. 5 out of 10. Okay. And did you enjoy the sleep? Was there any pleasure when you woke up? Did you think, oh, I really, really feel fresh today? And they say, no, there was no pleasure. I'm going to give that 1 out of 10. And what happened between 7 and 8? Well, all I did was I had a cup of coffee. Okay. 7 to 8, making a coffee and drinking it. Did you make a good coffee? Well, it was kind of average, I suppose. The milk was a bit off, but it was okay. What are you going to give that? A 3 out of 10. So that sounds like you've tasted better coffees, doesn't it? And did you get any pleasure? Not really. A 1 out of 10. So I think you can see how people are always doing something. And the question is, whatever they're doing for each box, are they mastering it? And is there any pleasure there? Now, I think you can see a target potentially from what we've said so far. How about if we try to make a slightly different type of coffee in the morning and see if you can manage it and see if it tastes any better and you get a bit more pleasure out of it. Now, that is the kind of target we're looking at. We're looking at building up slowly from there. So we're wanting to fill this in, and sometimes you'll need to help your loved one fill that in because they're maybe not got the motivation to do it, but they start to get into the way of it, and they usually start to see some interest in these different sorts of things. You find out that now they're slightly more interested in this different type of coffee, and they actually enjoyed it a bit better. And then maybe, now that we've got a little bit more pleasure from that, we can see other areas where we can slowly build. You're always doing something. Are you mastering it? And is there pleasure there? So we're going to score it on the activity schedule. How can we work with defeatist beliefs? Well, think about previous successes. Usually before the psychosis comes on, the person's had a reasonably successful life. Let's remind ourselves of them. Let's consider things that we're currently succeeding at, making that coffee, speaking to the social worker, etc. Use positive self-talk. This is an example of a patient who, before becoming paranoid, had actually ran a half marathon. So thinking back to then, it's an amazing achievement. How did you talk yourself through the pain barrier when your muscles were sore and you were tired? Can we get those thoughts up and running again? Is there a positive image there that you could work with? And of course, after his half marathon, at some point, he finished it. He felt really good and he got a certificate. Can you remember what that was like? Can he see himself in his mind's eye crossing that finishing line? Let's try and practice with that image. That is what you're capable of. But it might take us a while to ever get back to anything like that. Put the positive self-talk on a poster, a coping card, or record it on the cell phone. Now, we're going to have a question and answer session, but first on exercise, think about the elements of negative symptoms described in relation to your loved one and get a feel for what the main ones are. And as you were tackling the negative symptoms and helping with them in your caring role, which sort of old interests or hobbies might you include in some easy targets and goals? We've discussed time frame. What are you thinking about a time frame for your loved one to actually start to lift out of their negative symptoms? And in terms of that trajectory over the medium term, can you get a feel for what this balanced, low pressure communication style might be? Now, this is the great paper by Dr. Beck, Paul Grant and colleagues, which proves that even the most severe negative symptoms can improve. So I think if you're interested in the background literature, this is very inspiring. And if you put Aaron Beck negative symptoms into a search engine, you will find some of his key advice in this area.